Okay, everybody, so initial examination. So we're going to pick up, last time we were talking about the new patient checklist. We went over the intake, we went over the insurance verification. Intake 3 times as complex, insurance verification twice as complex. Last time we talked about this and we talked about electronic verification or outsourcing the verification of benefits being worth it in many cases. And of course, the other one is the explanation for the patient. And so we're going to pick up from here on the initial exam. When we talk about the initial examination, a lot of people think that this is something that you don't have to define because it's generally in the clinician's scope, and all they need to know is that they need to do it and they can take care of it. The reality is that that's not true, right? They generally, given the opportunity, will do what most people will do. As clinicians, we're going to focus on the things that we're good at, the things that make us more of an expert. What we want to do is focus them on building a community, not on simply building expertise in their own eyes, right? And hoping that that translates to the patient. So the first thing that we want to do is actually reconfirm the office tour. Now, this one can be made a little bit more specialized to the practice. What you want to do at this point as the major clinician, as the one that's going to be treating the patient now and probably for their entire treatment, their course of care, you're going to want to go ahead and say, hey, our assistant was supposed to take you around, explain to you what we do and why it's so great and why our community is so big and all that. I just wanted to make sure you didn't have any questions about it after you had that tour and you went and filled out all your forms and took care of everything else. Was there anything that you were curious about, anything about what we do that you're curious about? This is where we really take an interest in our patients. Generally, what you're going to see here is the time in your initial examination for your new patients is going to increase. But what you're going to find in the future is that your follow-up visit times decrease, because once you set up the expectations correctly that this patient is a part of a larger community, you're going to find that they're not as nervous, they're not as concerned with what you're doing, and so as a result, they're going to go ahead and kind of go along with you more. So they won't be as concerned about the decisions you're making or anything like that. They're going to feel like they're in good hands, and so your follow-up visits are going to go faster. And because generally follow-up visits are the bulk of our appointments, not new patient examinations, this ends up saving us in the long run a lot of time. And so we can actually see more visits if that's what we want to do. So we're going to go ahead and reconfirm the office tour. The next thing we're going to do is either confirm or reconfirm our chief complaints, or in other words, our subjective. So this is where we actually come together and we figure out what the patient is telling us is going on with them. So this is where we actually go in and we ask questions. We investigate, where does it hurt? What's bothering you? I've got pressure in my ear, or I've got headaches or migraines. I've got joint pain. I've got low back pain, whatever it is. This is where we start to investigate that. And of course, the next thing that we do is we do our testing. Right? And this is where we go ahead and we actually do our assessment of the patient. So this is where we'll go ahead and do x-rays, we'll do range of motion, we'll order labs, we'll do whatever we have to do. And once this is done, we'll assess and we'll either come up with a diagnosis or come up with a plan to do more testing if the issue hasn't been discovered just yet. So this becomes really critical here. The next thing you're going to want to do, this is critical, is actually review with the patient. Now, generally people ask me, well, wouldn't you do that with the treatment plan? We will also do that with the treatment plan. At this point, what you want to review with them is everything that you're doing. So imagine there's a great television show on the Golf Channel where it's called Playing with the Pros. And basically what happens is they mic up a professional golfer, like a Tiger Woods type, and they'll go out onto the field and they'll play 18 holes of golf, and they'll talk through everything that they do. So they'll talk about how they gauge wind and what club they choose and how they choose that club, and how they plan 3 steps ahead, where they're trying to hit it and why they're trying to hit the ball a certain way. It's the same thing we want to do here. We want to actually go over all this with the patient as if we're kind of going through an oral examination of sorts. You want to be comfortable, but you want to make sure the patient knows what's being done for them. Again, Generally, your patients, although you may think that they're coming to you because they're dependent on your care, and so you can take advantage of that and simply do things assuming that they know that you have their best interest in mind. These days, that's not so much the case, and patients need that reassurance. They need that hand-holding, and they need to be told things in a way that they're going to understand. So the review of the initial examination is really critical as it's happening and at the end. The next thing we want to do is actually review the clinical assessment. This is where we actually figure out exactly what is going on with our patient, and we go ahead and talk to the patient about what our findings suggest. This is really important because a lot of clinicians will simply tell the patient, this is what you have, right? You've got a separated shoulder. You've got a rhinovirus. You've got chronic sinusitis. You've got, a subluxation. Whatever it is that you think the patient has, or you're sure that the patient has, take a step back and make sure that when you talk to that patient about it, you're bringing it up saying, listen, I've looked at your assessment. We talked about what we did and why we did it. And it looks like it's leaning towards this root cause, this diagnosis. Now, am I 100% positive that that's the case? I'm very, very certain that that's what's going on with you today, ma'am or sir. But that's not always the case. We want to keep an open mind. We want to make sure that we're keeping options open, right? The problem that you always find is that if I diagnose you with this and it turns out you've got a separate issue, so for example, I diagnose you with chronic sinusitis and it turns out you've got Meniere's disease, right? Now we've got a huge problem because the patient had a certain level of expectation and now you've given them a new diagnosis with a 20-year prognosis, right? Now we've got a huge, huge problem. So we want to leave the door open here, and we want to leave it open with a plan to investigate those options. We don't want to tell them that, well, we're not sure and we're not going to do anything about it. We want to tell them that we're really, really positive, but on the off chance that something else is hiding under the surface, we're going to keep following up. We're going to keep figuring out if there's something else causing this while we attempt treating this, because this is the most likely cause right now. And that's where you review the clinical assessment, and this is where you review treatment options. So this is where I say, okay, first I get their confirmation. We agree that this is the most likely cause. Now we're going to go over the different things that we can do. So for example, you could try prescribed medications, over-the-counter medications, homeopathy. You can try other services that are linked to your diagnosis that might help you. Basically, you want to establish yourself as the hub for that patient's care on that diagnosis. So I'm going to put that here. I'm going to call that establish the hub. This is really critical because generally, no matter what the diagnosis is, there's going to be other things that could supplement their care and get them better faster. So, for example, chiropractic, I've got a subluxation, I'm going to adjust you. There are home exercises you have to do. You go to a physical therapist. I've got a separated shoulder. The physical therapist is going to say, okay, when you're here, we're going to do a certain number of manipulations and exercises and things like that. When you're home, go do these other things. Acupuncture might help, by the way. Your doctor might prescribe you an anti-inflammatory. All these other services. But the most important thing is you want to establish yourself as the hub for that patient's care. So whenever the patient experiences something new, they come to you with that first. They don't go to any other specialist with that because if you're the hub, now you've got a full picture of what's going on with your patient. So we want to review the treatment options. Then we want to commit our patient to the treatment options we most highly recommend. So we might say that, for example, separated shoulder, the treatment option that I'm recommending most strongly, patient, is anti-inflammatory, over-the-counter, ibuprofen. I'm going to recommend Treating Your Own Shoulder by McKenzie for some home exercise work. I'm going to recommend that you go to a physical therapist. I'm going to recommend that you get adjusted. I'm going to recommend that you see an orthopedist for a possible surgery. Those are my recommendations. And I go through one by one and I say, is that okay with you? Are you on board with that? Do you have any questions about that? Remember, I'm not asking these questions to actually, debate medicine or debate healthcare with the patient, right? Because I don't want them to be Wikipediaing everything that I say. What I really want from them is buy-in. What I really want from them is a verbal commitment to the care that I'm proposing. So at that point, I've got their commitment to the treatment plan, and I've established it. Now I'm going to want to go ahead. I'm going to want to go ahead and actually schedule the treatment. Now, that might include writing out a prescription, actually scheduling repeat visits. If you're a specialist, especially if you're in a specialty where you have chronic conditions, one of the biggest mistakes I see when I consult with practice owners is that they do not automatically schedule follow-ups quickly. The biggest thing you see is, I want to see you again in a month, in 2 months, in 3 months. Regardless of the condition, the first follow-up should be very soon after the initial exam. You may not find anything drastically different at that follow-up, but it commits that patient to care, and it opens up the opportunity for symptoms that you weren't aware of before that the patient experiences again in that time frame. So for example, if you're dealing with a chronic sinusitis, that patient may have reported, stuffiness and everything related to chronic sinusitis, and they didn't bring up dizziness. They come in 2 weeks later, a week later, because you scheduled smartly. You scheduled a follow-up very quickly, and they come back and they tell you, you know what? I just had an episode the other day. My chronic sinusitis flared up, and I was very, very dizzy. The whole room tilted. It was spinning. Okay, well now we need to look at a different option. Maybe we're talking about Meniere's disease. We're not just talking about a chronic sinusitis here. So we want to make sure that we're scheduling that treatment plan, and when we're scheduling follow-ups, the first follow-up is scheduled as soon as possible after the initial exam within reason. Remember, we always want to stay compliant, right? So the next thing we want to do here is collect the payment. Now, when we collect the payment, this is very critical. The first thing you want to do in a PCI compliant way is get a payment method on file. This is critical because one of the recommendations I make to any practice owner is you should have a no-show policy that says that in full or in part, some part of that patient's care has to be accounted for. So for example, if you missed the appointment and we didn't know about it, we have to charge you a certain amount of dollars. The goal there is not to create a revenue source for the practice, of course. The goal there is to commit the patient to care. Now, what happens generally in the case where a patient misses an appointment and doesn't tell you about it, or skips the appointment and doesn't tell you about it? This is an opportunity to solidify the relationship. This is where you can come back and actually recommit the patient to care. This is where you can say, listen, technically I should charge you the full $50 copay or $100 visit charge for the visit that you missed. However, the most important thing to me right now is that you're taken care of. Can you get here tomorrow at 3:00 p.m.? If you can, I'm going to go ahead and waive that fee. The most important thing to me is that you're taken care of and that you're getting better. Whenever you're having this conversation, whenever you're trying to take care of a patient, remember, the goal is not initially to create a revenue source. The goal is to get the patient better. Because why? If I get this patient better, they're going to refer their family and friends. And when they do that, that's my revenue source. That referral tree is the revenue source that I'm trying to create, not simply to collect the dollar from that one patient. It's a mistake. In fact, it's better for you if you've got a bad patient to simply refer them out to another clinician if you just cannot connect with them for whatever reason, than to hang on to them and have them poison your community. So, we've understood that recommitting the patient to care is another part of collecting the payment. The other part of collecting the payment here is reviewing policies and office options. So this is where you can actually say, in a multi-specialty situation, by the way, I know you saw Dr. Roberts for your chronic sinusitis. Did you know that we keep a chiropractor on staff because we find that adjustments seem to help with the symptoms? Would you be interested in scheduling an evaluation with our chiropractor? This is where you actually get to do a cross-referral where you can actually get more of your services to a patient that needs it. So as you can see here, we took 5 steps that most practices take today and increased it to 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16 different steps every time you have a new patient. 15 to 16 steps, that's over 3 times more complex. There's no way you're going to do that on paper successfully every time, and there's no reason that you should. PY Technologies has products specifically developed for this, and products that are coming out in the next few months, in the next few weeks, that are going to make it even easier. So stay tuned for more on this, and next time we'll kind of take the whole thing together and create a picture of what's going on. Take care.